Well, hello everyone. Welcome to part 3 in my second lecture for today. I've just left you on this Monday afternoon, and I'm going to try to get the rest of this up so we can move on. We've got so much we've got to do, and I'll try to get through these as quickly as I can. We're now talking about the secondary assessment. We're talking about really scanning and cataloging injuries and the methodology for doing that. Case study 2, this is the second of this particular lecture series. EMTs Ryan Webb and Bruce Hart have just approached a vehicle that has collided with a large tree. The scene is safe and the driver of the vehicle is the only patient. However, the patient is trapped in the vehicle and extrication equipment is still 2 minutes away. The front end of the vehicle is heavily damaged. The patient, an adult male, is in the driver's seat, but his head is down and he's not moving. He does not respond to Ryan's voice or to having his trapezius muscle pinched. The patient has snoring respirations at a rate of about 12 per minute. Ryan is able to enter the rear of the vehicle and position himself behind the patient to open airway and stabilize the spine. The patient's respirations are shallow and his carotid pulse is weak and rapid. And the plot continues to thicken. Bruce hands Ryan a bag valve mask to start assisting the patient's ventilations. There is some bleeding from the patient's scalp and nose. Bruce suctions the airway and applies a pressure bandage to control the bleeding from the scalp. Things we want to think about here. What is the nature of the patient's problem? Well, we know he's got a bump on his noggin. His LOC is obviously off. Our second question asks, is the patient stable or unstable? And to explain your answer, what did we say, if you'll recall, what did we say about stable and unstable when we're talking about a primary assessment, which is what our Ryan and Bruce here are doing initially? We said that any deficiency that we found in those critical systems that we could not correct relatively quickly and fairly easy would bump up the priority of this patient. It would bump it up to a higher priority. So I'm going to go with my first instinct here, probably myself, and say that this patient is unstable. We have obviously got a deficit, however permanent or temporary, we've got a deficit in the level of consciousness. So I can't fix that readily. A lot of things I can help. I can't do much if they've got their noodles scrambled. How should Ryan and Bruce proceed with further assessment and treatment? Well, they're waiting on extrication. For now, I think I would file the priority in the back of my head and proceed with my examination, because I'm not going anywhere until somebody can get this patient out of the vehicle. The secondary assessment is, as I said, it's a cataloging of injuries. It's finding injuries or finding occurrences that signal other injuries. The assessment is, of course, different for medical patients than it is trauma patients. And whether the patient has a minor or a serious complaint, how in depth we're going to get with our secondary survey really depends on the nature of the situation. The secondary assessment is comprised of 3 basic procedures: the physical exam, the baseline vital signs, and the history. All of these are extremely important. We tailor our assessment to the needs of the patient and the suspected condition or injury. And be careful with that. Make sure you know the needs of the patient or the suspected condition or injury before you start tailoring your assessment. Sometimes it's a little harder to nail that down than it looks. Physical examination uses the techniques of inspection, palpation, and auscultation. These are the tools God gave us, for the most part, to identify signs and symptoms. An anatomical approach proceeds from the head to the feet. Okay. Probably the most important thing about this slide is the first bullet. Well, it's important. The secondary assessment should be conducted systematically, starting at the head and moving to the feet. Top to bottom, a rapid secondary assessment is performed on unstable or critical medical or trauma patients. If you go back to our case study, and we had deemed that our patient was unstable, so we're going to continue a rapid secondary assessment. Again, we're stuck. And they're pinned, remember, and I'm waiting for somebody to help me get them out of there. But the technical correct answer to that would be a rapid secondary assessment. We want to be able to move pretty quickly once we're able to. And we've mentioned this in class several times. If you've got a significant mechanism of injury, potential for multi-system trauma, then I need to see that patient. Yes, I'm going to try to protect their privacy, but I need to see where these injuries may be and what type of injuries we're going to be looking at. It doesn't take long. If you've got a decent pair of shears, you can strip somebody pretty quick, and sometimes that's what's necessary to do. Again, I will caution you, please try to protect them and their privacy, but to me, their life is worth more than their privacy at this particular moment in time. These slides, the next 17 of them, if I'm reading that correctly, we're going to go from the head to toe. And we've talked about this in class. We've talked a little bit about it. We've actually done a few of these, and I've mentioned it. So this may be a little bit redundant. Just bear with me. I want to make sure we do cover this information. Assess the head. We want to inspect the head and scalp for deformities, contusions, abrasions, punctures, burns, lacerations, or swelling, which is a lot of words to say I want to inspect the head and scalp for any injury, period, that I can find that shouldn't be there. Of course, no injury should be there, but believe it or not, some people do have abnormalities in their head that may be normal for them. That's not what I'm looking for. I'm looking for any new injuries. I want to assess the eyes, ears, nose, and mouth. And we talked a little bit about this in class. You're basically inspecting for the same things. You want to make sure that the eyes are not damaged. You don't have anything coming from the ears, whether it be blood or cerebrospinal fluid. That goes for the nose and mouth as well. Bleeding from the mouth can be very deceptive. It's not hard to bite your tongue or bite the inside of your jaw or have a tooth damage and have a impressive amount of blood, but ultimately it's not significant. On the other hand, never assume that's what it is. If they're bleeding from the mouth, it could be from an internal injury that's just coming out up through the esophageal tract or the trachea. You have to the rest of your examination may give you clues to where that's coming from. I also mentioned to you that the head, if you remember this, the head and the face, and yes, the tongue and the mouth, these are very vascular areas. They have a very rich blood supply, and they can bleed considerably and even look like they're bleeding worse than they are. Sometimes these are distracting injuries. Yeah, they've got a laceration and they're bleeding from it. Yes, I'm going to eventually, address that. But just know that these areas will bleed, and it may not be a life-threatening problem, but it can look like one. It can distract your attention away from what you need to be looking at. So be careful there. Here we go, down to secondary assessment. I'm going to run these slow enough for you to see the pictures, but they're the headers say it all. Inspect the head for signs of trauma. Carefully palpate the skull for abnormalities. Be careful when you're palpating a skull for abnormalities, particularly if you suspect some are there. If you've got a place, an unstable part of the scalp, or excuse me, the skull, I really don't want to be jamming my thumbs in it. I don't want to be putting more pressure on the brain. So be careful. You want to find them. You don't want to make them worse. Inspect and palpate the ear. Notice any leakage of blood or fluid. This could be significant. We've already said why. Inspect behind the ears for injury or discoloration. Remember, we talked about battle sign, which is bruising over the mastoid process, usually indicative of a skull fracture, probably a basilar skull fracture, but indicative of that. Quite common. Common enough that it has a name. Inspect and palpate the face. Notice any deformity, instability, burns, or swelling. I think I mentioned briefly, because we hadn't quite got here yet, I mentioned Lefort fractures. We mentioned where the skull can be fractured through the orbits, through the maxillary area. There are different degrees of Lefort fracture. We're not really going to get too deeply into that. We will. We're not going to get into it right here. But you can also have instability in these areas. The zygoma, the cheekbones are particularly vulnerable and can be broken with only a moderate amount of force. Depends on how it's struck. We practice this in class, assessing the pupils for equality and size of reactivity to light. Inspect the color of the sclerae. Petechial hemorrhages sometimes can be signs of compression injury or strangulation. That's really broken blood vessels in the eye. If you see this with a compression injury, I would imagine your patient's condition is pretty bad. You might be looking at something like traumatic asphyxia, is what we used to call it. I have another name for it. It's called DEAD. I've never had a traumatic asphyxia patient who actually lived. The mechanism behind that is quite extensive. It's basically where blood is forced the wrong way back through the heart, blows out the valves, up into the great vessels of the neck. Usually the eyes are very red and bulged out. It's not pretty, and I've yet to have one that survived. I'm sure there's other medics out there who have a different story, believe me, but I've never had a true traumatic asphyxia patient that survived. Eye movement. We talked about the reason for this. This is actually an evaluation of the cranial nerves, most particularly the third cranial nerve, which is the oculomotor nerve, if memory serves, because I'm not having the notes in front of me and I'm just pulling that one off the top of my head. Inability to move, to follow the finger, might mean either damage to the eye if one eye is not able to do it, or it could be problems with the CNS or the cranial nerves if they can't. Note any gazes in one direction or jerky eye movements. We talked about nystagmus. We talked about when the eyes jerk involuntarily to one side, and that can be caused by a lot of things. It can be caused by alcohol or drug use. It can be caused by disruptions in the inner ear. It can be caused by CNS problems like bleeding into the brain. So make note of those, and more importantly, keep track to see if they're getting worse or they're getting better. Inspect the conjunctiva by pulling down the lower eyelid. This also can give you a little bit of an idea of perfusion status. Sometimes you can see pallor or cyanosis in this area. Your perfusion status is probably pretty bad. Inspect the palate, the nose for any signs of trauma, burns, bleeding, or fluid leakage. We had talked about that. Cerebrospinal fluid's not going to gush as a rule, guys. It's going to trickle. When you've got a basilar skull fracture and cerebrospinal fluid is leaking out. So, don't make the assumption that their nose is just running. It could be something. It could be more than that. Inspect the inside of the mouth for signs of trauma, burns, and discoloration. And there's another note. Note the color of the mucous membranes. smell the breath for any unusual odor. And they're guiding you toward alcohol or perhaps a acetone or fruity type smell from diabetic ketoacidosis that you're looking for in that. That's what you might find there. From here, we're going to assess the neck. We're going to look for signs of injury. We're going to cover any open wounds. Look for jugular vein distension. I imagine, again, if you've got it in the setting of trauma, that's possibly some type of obstructive problem, such as a pneumothorax, or you wouldn't have it with a hemothorax, you'd have it with a pneumothorax, or, as again, that compression injury. Of course, in the true traumatic asphyxia, they'll be really distended, and as I said, your patient's prognosis is probably pretty bad. Palpate for tracheal deviation. Takes a practice hand to spot tracheal deviation simply by palpating. It takes a practice eye to see tracheal deviation, because the point of fact is it often deviates below the level where we tend to look directly at the trachea. One of the last times I caught tracheal deviation, I was actually loading the patient and looking up the long axis of the patient from the feet, and noticed that the trachea was just ever so slightly out of midline. And when I was up at the head end of the patient, I didn't see it. It was just easier to look at it along the axis and spot that it was out of the midline. And here we have a picture of someone doing exactly what we just said. Looking for JVD, we're looking for tracheal deviation, accessory muscle use, subcutaneous emphysema. Yes, if you have that compression injury and they happen to be alive, you probably are definitely going to feel subcutaneous emphysema, but also with a pneumothorax. Pneumomediastitum can give you that too, and it's very hard sometimes to differentiate those two in the field. I've seen very, very good ER docs miss that one, at least until they use some advanced diagnostics to find it. From here, we're going to go to the chest, and we're going to use our tools again. We're going to inspect and cover open wounds. Be very suspicious of open wounds on the chest. What may look simply like cuts could go a lot deeper than you think, and if that cavity is penetrated, do I even need to say it? Our pressure chamber is no longer a pressure chamber anymore. It's going to compromise our respiratory efforts. Look for paradoxical movement. Flail segment is an immediate life-threatening condition. When you have a segment of ribs that are broken, usually in two places, and it's going in while the rest of the ribs are going out, well, it's painful for one thing if the patient's conscious, but it's also making it more difficult for that patient to breathe, and our pressure chamber is not working very well. We're going to have to stabilize those sections. We'll talk a little bit more about that when we get to it. Right now, we're just noting it. Palpate the chest. We talked about equal chest expansion. Believe it or not, this is easier to hear than it is to see, but if you are in a situation where, let's say you've got 15 diesel engines running and 2 Hirsch tools and you can't hear, you can actually palpate the chest, as I showed you, using both your hands, and watch for bilateral equal rise and fall. Auscultate breath sounds. This is probably your best way to figure out where you got one lung that with sounds that are less pronounced than the other. But we do need to find out what we've got there. We need to auscultate the lung fields. Gosh, I've talked so much today, I'm having trouble talking now. Auscultate the breath sounds, because it can tell you a great deal given a specific pathology. And here we have a visual interpretation, a picture of inspecting and palpating the entire chest. Check symmetry of chest wall movement, palpate the sternum, clavicles, and shoulders. And I'm going to have to stop with this slide and get up and stretch a minute, because I'm starting to slur my words. I've been talking today. I've already lectured for 3 hours, and now I'm doing this one. So we'll pick it up in just a second. Okay, I'm back. Maybe a little more coherent. a word on palpating anything. Sometimes the deformity is obvious. Sometimes it can't be missed. Anybody would spot it. Sometimes the deformities or disarticulations or whatever you might find is a little bit more subtle. And right now, you haven't put your hands on a lot of people. But when you put your hands on a lot of people, this becomes a little bit easier. But it does take, like anything, it takes a practice set of hands to be able to pick up on one of those subtle injuries, one of those subtle deformities. You'll get better at it over time. We have done this in class, auscultating breath sounds, comparing one side to the other. They should be fairly equal unless the patient has some type of pre-existing condition that would cause it not to be, which would be an extremely small percentage of patients, but it should be equal, bilateral equal, and it should be reasonably clear. And this is something else that takes a lot of practice, guys. You've heard me say this in class over and over. This is why I want you in your clinical settings and in your field internship to listen to lung sounds on every patient that you can. You need a catalog of lung sounds in your head so that when you hear abnormal lung sounds, you'll know what you're listening to. Then we're going to move on down to the tum-tum, the abdomen. We did this, I demonstrated this in class, inspect and palpate all four quadrants and laterally. Look for distension of the abdomen or discoloration and excessive bruising, for example, of any of those areas. And remember what I said about things like rebound tenderness, which can be indicative of peritonitis. If something hurts, or if a patient tells you that an area of the abdomen hurts, go there last. Because if you go there first, you're not going to get to complete your exam. If you find pulsating masses, it's probably a time bomb in their belly in the form of a dissecting aortic aneurysm. Yeah, you don't want to poke that. That could be catastrophic if that thing should rupture. Definitely want to try to find them. You want to make note of them. They are stunningly bad things to find and bad signs. Check for signs of peritonitis. And I mentioned that. A rigid abdomen, I find it very hard to believe you're going to get too close to someone with, as far as an exam goes, with peritonitis. They're going to be probably guarding something fierce. But if you are able to, and you depress in slightly when you palpate, let out quickly, you get that rebound tenderness that can be a sign of peritonitis. The peritoneum, guys, is a sensitive structure, and it pretty much doesn't like anything next to it that's not supposed to be there, even the patient's own blood. Even the patient's own blood can cause it to be irritated. Infection also can cause it. It'd be a pretty bad infection, usually secondary to some type of internal trauma or surgical intervention. But it will eventually get rigid. Keep in mind that that's a relatively late sign of peritonitis. Usually the pain of peritonitis is diffuse. It's not localized. It's usually, not one particular area. It is across an area of the abdomen or the entire abdomen. So keep that in mind as well. And this merely is a picture of someone doing what we talked about. What are those marks on this guy's belly? Like scratches. Who knows? This next picture anyway is talking about the heel drop test, and this kind of plays into what I said to you in a couple of slides back about people with peritonitis. And I'm not expecting you, if they've got peritonitis, to get too much of a abdominal exam in, because they're just not going to let you. Peritonitis is extremely painful, but the heel drop test, and I think somewhere on here we'll have the heel bump test. They both fall into the category of Markle's sign. They help you identify patients with peritonitis. If it I must say, I've never used this in the field. I haven't. I don't. I haven't really needed it to make me suspicious that someone has peritonitis. You can also use it for appendicitis as well. Both of these will work for that. The bottom line is you have them stand up on the balls of their feet and then drop to their heels, and it causes them a lot of pain, and that's considered a positive sign. Again, this is calls under the Markle test or Markle test. So I've never used it. I'm not saying it's not completely legitimate. Go for it if you want to. This is the second half of it. You had them stand up on their heels and drop down. Note that one person was back behind them in case the patient was to stumble and fall. I'm gonna speculate that perhaps in very early peritonitis this might be of some use, or appendicitis possibly, that this might be of some use. I just never needed this test to tip me off to the possibility of peritonitis in a patient. Many times when I interview the patient, what they tell me sounds like peritonitis early. Keep in mind, I'm not going to treat the peritonitis. I don't do that. My big thing is to suspect it and recognize it and get them where they can get to care for it. This can be a very dangerous problem. This could be a life-threatening problem if it's allowed to progress. There's the heel jar test. Another Markle test. And there's other. I've seen other variations of this where you simply just walk up and push the top of the feet back toward the head just briefly, and it causes pain. And I'm not going to tell you can't do these. It's fine to do them. I've just never used them in the field. I never really needed them. But I do want you to be aware of them. Let's talk about the pelvis. Used to be an old, well, it was BTLS, Basic Trauma Life Support. Now it's ITLS, International Trauma Life Support. Used to be an old test question of what were the two secondary survey findings that would bump the patient up to a load and go. And one of them was a pelvic fracture. The other was bilateral femur fractures, just so you'll know. And that's still true. It's still a critical injury to find. If you've got a lot of super large vessels that run through the pelvic girdle, and the back of the pelvic girdle, the posterior of the pelvis actually protects those vessels pretty good, but anteriorly they do not. You don't have a lot of armor up front. So pelvic injuries can be critical. Now, the slide is absolutely correct. We don't go playing with somebody's pelvis if they have obvious injuries. There's just no need. The fact that we know that it's fractured, all we need to know. We know we need to expedite this call, and we know that this patient has very serious and significant injuries. Ironically, we talked about this in class today, priapism. I don't tell you to go looking for a priapism because it's indicative of spinal injury. I've also seen the same thing happen with gunshot wounds to the head, but it's generally associated with spinal injury. It's one of those things that you might note, but we don't tell you to go looking for it. And there's a very simple reason for that. Most likely the type of patient that I'm going to find a priapism, I'm already taking spinal precautions. It doesn't tell me anything I don't already suspect or I'm not already defending against. You may, depending on how the patient's dressed, you may elicit this. You may see it. It's just one more piece of the puzzle as far as a potential spinal injury goes. But I hope by the time you get down to being able to pay attention to that, you're already taking spinal precautions if you think it's necessary. And here we have an illustration. We did this. We talked about compression checks on the pelvis, gently pressing in, pressing down, rocking the pelvis occasionally. I'm going to let that go with that. Okay, let's talk about the lower extremities. And we're going to look for signs of injury or edema, deformity. A joint where a joint's not supposed to be is always a good sign. Bone end sticking out is always a good sign. Signs of deep vein thrombosis. This actually kind of surprised me to be on the slide, but yeah, it's possible. It usually starts out with something like a pain in the calf. You might have one leg that is swollen, rarely both, but you could have one leg that actually has a temperature differential from the other. This is one of those things that the reason I'm surprised is, yeah, I might make note and I might be suspicious of that depending on the complaint, depending on what I've been called there for. But this is something else I'm not going to treat. Patients who have these, I mean, they're the bad thing about blood clots in the lower extremities is they don't tend to stay in the lower extremities. I mean, you don't want the circulatory deficit, but they tend to break loose and go to nasty places like the heart and the lungs and the brain, and then become really big life-threatening problems. Your patients who have this problem, some people live with it, you should also know that there's sometimes no signs of deep vein thrombosis. I don't, as left to my own devices, I doubt I would have mentioned deep vein thrombosis because, frankly, it's just not my corner of the street. That's for a doctor to care for. Then again, I often see patients who suffer from this. I often see the results of what happens when they move, when they go somewhere else and lodge in the heart, the brain, or the lungs. We always check pulse, motor function, sensation in the lower extremities and all extremities when we're doing a patient assessment. We also can check capillary refill. But the big pulse, motor function, sensation, most definitely we want to make sure that we verify. And here we are. Let you look at that for a second before I move on. You know, I try to be a good boy. I really do, and toe the party line where these lectures are concerned. And I'm certainly not telling you that this is not something you can check when you're doing a secondary assessment. This is checking for pain in the calf during dorsiflexion and plantar flexion. And this is not something else I do because really there's I think about half a dozen things that might cause pain in the calf, everything from sciatica to Achilles tendon problems. Most likely what they're pushing is toward here. It goes back to deep vein thrombosis. This is a test you can do for it. I'm certainly not against you doing it. And the other one may be diabetic peripheral neuropathy. It's cool if you find that, if you find either one of them. But as I said, this is probably not going to be my street corner. This is going to be, there's not much I can do about it. And in most cases, as far as diabetic neuropathy goes, the patient probably knows it, that they have it. So it's not going to be an earth-shattering finding. I suppose it's possible that they don't. And as a matter of fact, very possible. Most things in medicine are. But yes, do this. You want to do this. I'm not going to lie to you and tell you I ever have. It's just not been a big. If I've asked them to do anything with their foot, it's to push against my hands and then pull back against my hands. And I'm evaluating motor and sensory function, or motor function specifically. So, nice little flourish that they threw into this one, but I can't tell you that I'd routinely do it when I'm assessing a patient. Distal pulses in each lower extremity. Also note skin color, temperature, and condition. All of this is very valid. We are wanting to see what our perfusion status is at the farthest reaches of the body, especially with the feet. We're way down low. And this is just what I told you about a couple of slides back. Motor response of the lower extremities. And it is important that you note that the equality, because they should be able to do it unless they do have an injury in one extremity or a problem with one extremity or a previous stroke or a current stroke, as far as that goes. They should be able to push equally. Testing sensory function. I frequently will ask, which toe do I have a hold of if they're barefoot. I'm kind of light on the pain response. I just want to make sure they can feel. I usually take it for granted that if they can feel pain. I kind of feel like they're having a bad enough day without me hurting them, so I try not to do it any more than I have to. But a little pinch on the toe probably ain't gonna hurt anything. So you can see what their reaction is to it. The upper extremities, same thing. We look for signs of injury. We look for deformities. We look for anything that shouldn't be there. We check for pulses, motor function, sensation. If it's applicable, we perform a stroke assessment for arm drift. And I've seen this arm drift test done a lot of different ways, and I think we make it a little harder than it needs to be. I think one of the big mistakes that a lot of practitioners make is when they have the patient hold their arms out in front of them and they let them keep their eyes open. And if you do this, patients usually try to give us what we ask for, and if we ask them to hold their arms out evenly, they're going to try to do it, even if it means compensating for a weak one. Have them close their eyes and see if that arm drifts off, and they won't even be aware of it if we're talking about a stroke. They won't even be aware they've done it, but they may try to compensate if they can see it. Now, I'm sure there's some other practitioners and instructors out there who say this is an unnecessary step or whatever, but that's the way I like to do it, and I like to see you do it. The fact is, I've seen myself how people will try to compensate. They try to do what I ask them to do, bless their little hearts, and they frequently will screw up my assessment if I let them. And here we go. We're inspecting and palpating the upper extremities. Not going to belabor that. We assess the radial pulse on each upper extremity, and again, we look at skin color, temperature, and condition. And I bet you I know what's coming next. Testing grip strength. Very common assessment tool. I've used it many, many times. It's quick, it's easy. Have them take 2 fingers, squeeze these fingers. I will tell you this, if you're evaluating a stroke patient, the grip is probably not the best one to use. Having them push against your hands and pull back against your hands is probably better, because I don't claim to be a neurologist, but as I understand it takes separate muscle groups and separate parts of the brain technically to accomplish this. So if you're evaluating their ability, their neurologic abilities, it might be a better test. But this is good, and it's effective, and I guarantee you probably 90% of the medics out there use the grip test. It's still valid. I'm not saying it's not. We do the same thing as we do with the feet. We try to figure out which finger, ask them which finger do I have a hold of, ask them to wiggle their fingers. We check capillary refill. Depending on the environment, it should take no more than 2 seconds. And I actually recently saw something that said 3, but I still like my 2, and I'm sticking with it. Well, I'll be. Here I thought I was giving you deep and unknown information, but they have actually come around to my way of thinking. I'm a very influential person. Yes, have the patient close their eyes and hold their arms, and then check for arm drift. They will try to compensate. See a lot of medics stick people's arms out in front of them with their eyes open, and they don't understand that just because you're having a stroke doesn't mean you still don't have some ability to control that weakened extremity, and you might try to compensate to give the person who's examining you what you ask them for. The posterior body. I'm going to say it again. I know you're bored with it, and I'm getting bored with saying it, but it takes a practiced hand to palpate a spine and know anything but the most obvious injuries, the most egregious displacements. Of course, you might find a step off there, you might find something like that, but it really takes a practiced hand. I've been doing it for well over 30 years, and my hand is not practiced enough to find some injuries. You need to see someone who deals with backs all day long, who has a lot more letters beside their name than mine, because that's what they do. And to be honest with you, just to be frank, I doubt they rely as much on their palpation abilities as they do an X-ray. But we do check it. and we do look at the back, and we're looking for anything else that's not supposed to be there, just like we do anything else. And that includes the thorax, lumbar, buttocks, and lower extremities. The butt will bleed, and I'm talking about the gluteus. The muscles will bleed. It's a vascular area. It will bleed. It may look worse than it is. Looking for bleeding, anything out of place on the back. Once you've found a problem, consider all the body systems that might be affected. In our case study, I'm fully expecting that all the body systems will be affected because the guy's got his egg scrambled, apparently. We don't know to what degree, and we don't know exactly what type of injury, but we know his responsiveness is off. As a matter of fact, he's unresponsive, at least if I remember the case study that well. It's important to link body systems together. It is. The body's a magnificent machine, but it is interdependent. Systems depend on each other. So, I mean, we as EMS personnel, we tend to focus on, I don't want to say the large systems. We focus on all systems, but we talk about the head, we talk about the heart, we talk about the lungs. But all of the systems, we learn to think on a systemic level. Hypoxia, for example, that's going to affect everything. If the computer's not working, if you've got a head injury and the computer's on the fritz, that's going to affect everything. The heart doesn't work, nothing works. So, just a word to the wise there. The body systems approach, and this is where we look at the systems, and the respiratory system, chest shape and symmetry, excessive muscle use, auscultation. By auscultation, what do the lungs sound like? They sound like a washing machine? Well, we got issues if they do. We've got fluid in the lungs. Are they, one lung sounds there, the other one's not, or very distant? We got a problem. We have a mechanical problem within our pressure chamber that could become critical and probably will very, very quickly. So the whole respiratory system can be evaluated with looking at the signs and symptoms produced. When we're evaluating the cardiovascular system, we look at the peripheral and central pulses, the blood pressure. I would argue you also look at the general appearance of the patient, the general responsiveness of the patient. Someone whose cardiovascular system is on the fritz may not be perfusing very well, and they may look like death. But pulses, the presence of pulses, we're talking about a quick exam here, so I'm not going to beat up this slide too much over that. The presence or absence of peripheral pulses and the central pulses and the blood pressure. Great evaluation, quick evaluation of the cardiovascular system. The neurological system. Best of all is the mental status, not only where it is when you found it, but where is it going? Do they stay conscious? Were they conscious and now they're not? Were they unconscious, now they are? All of these are significant findings. Posture and motor activity, there's a word, ataxic, like ataxic movement. It's where the movements are jerky and out of sync, and it just looks like they're not fluid at all. Facial expression, speech, mood, memory, all are offshoots of the neurological system. And the neurological system can sometimes it's very easy to evaluate a problem with the neurological systems. Sometimes it's very subtle and it's very hard. Those are the insidious ones. Those are the ones that are there right in front of your face, but they don't present themselves immediately, that you have to dig a little bit deeper and have a high index of suspicion to find. Memory is also very good. The last one of the bullets here, we talked about retrograde amnesia. We talked about antegrade amnesia, which seems to be more rare. Retrograde amnesia, it takes some time for things to pass from short-term to long-term memory. You get your bell rung and rung hard enough to wipe it out of short-term memory, and you can't remember it. This is why I've had people. My little brother I told you about was in a terrible accident. He has no memory up to this day. He does not remember the accident, and he got his bells rung pretty hard. It's not uncommon at all. The famous television plot line is when their character is well, actually, it's a general amnesia where they just lose their entire memory. Uh, Antegrade is kind of freaky. They have a memory up to a certain point and can't seem to retain things that have happened following the injury, and that's generally because the memory areas of the brain have actually been disrupted or damaged. We ask patients to do a lot of silly things. Stick your tongue out. That's one we ask them to do. And if we're suspicious of a stroke, um, the tongue will go to one side or the other because the muscles that control the tongue to stick it out, one side is weaker than the other. The same thing with the smile. We have people smile to see if the smile is symmetrical. If we have half of a smile, then we can assume that we've got weakness of the muscles on one side of the face, or paralysis of them for that matter. The musculoskeletal system, the pelvis we've talked about, the lower extremities, upper extremities, we check the extremities for perfusion status at the distal points of the body. We want to see if we've got reasonable certainty that we have an intact circulatory system. Doesn't mean it's completely intact, but if we've got peripheral pulses that are equal and strong, and we've got good color, we've got good motor and sensory function, we can assume that they're reasonably intact. And of course, the posterior body. Be very careful about not checking the posterior of the body because we talked about how blood tends to pool sometimes, and it can actually hide from you in the small of someone's back, clinging to their clothes, and it may be bleeding into the clothes or being absorbed by the clothes, and it can be worse than you think it is. So you have to go looking for things like that. If you recall, when we were talking about vital signs, we listed that people sometimes list the big three, which is pulse, respiration, blood pressure, but all of these that you see in this slide, breathing rate, tidal volume, pulse, location, rate, strength and quality, skin, temperature, color, condition, appearance, which is not on your slide, capillary refill, blood pressure, the systolic, diastolic, of course, pupils, the quality, size, rate of reactivity, and SpO2. All of these are considered vital signs. They're all pieces of the bigger puzzle that we need to put together. I don't know if you guys can tell, I'm losing my voice because I have been talking so long today, this morning and now this afternoon. I apologize for that, by the way. Attain the history, the sample history, signs and symptoms, allergies, meds, past medical history, last oral intake, and events prior to this event, events that led up to it. Very important information, all of it. We talked a little bit today about a very important question I like to ask, depending on the circumstances, have they started or stopped any new medications or any medications? Many times, a lot of our calls come down to the patient adjusting to a new medication, particularly to blood pressure medications and blood sugar medications. We see a lot of these patients. Our OPQRST, which is onset, anything that provokes, or palliation, which means does anything make it better or worse? Any position you could set, anything you could do. Describe the pain, the quality of the pain. Is it sharp? Is it dull? R, radiation, is it going anywhere? Is it one place or is it going somewhere else? And how severe it is, this is probably one of our weakest parts of our evaluation because we only have a very subjective, on a scale of 1 to 10, well, what's 1 for me might be 10 for you and vice versa. But we still try to evaluate the severity of the pain. I tend to look at unconscious indicators of pain, body position, how they're holding themselves, are they sweating, wincing. I tend to lean more toward those observational things than I do a subjective number that patients may give me. I may have cut myself off because I don't remember pulling this slide up, but there it is, so let's go on. The general sequence, physical exam, vital signs, history, same with trauma patient. We do the same basic things, a little differently, a little different, same priorities, but we evaluate them a little bit differently. This particular slide is talking about reevaluating the mechanism of injury. It's talking about your index of suspicion. How did these injuries occur? What was the mechanism? What types of force were exerted upon this patient, which can lead us to anticipate certain injuries during the secondary assessment approach. Just a very big, long algorithm that you're going to have trouble seeing. I'm not going to go down this. Believe it or not, if you learn the steps as we've taught them, you will know this. This particular slide kind of reiterates what I just said. The more significant or severe the mechanism of injury, the greater the chance that the patient is critically injured. The more force that has been exerted, that has been set in motion and absorbed by this patient, generally speaking, the more injuries they're going to have, and the more severe injuries they're going to have. Take a moment, as you, for example, a car accident, take a moment to look at, if you can, sometimes you just don't know. You got a car in the middle of a field, you're not sure what happened, but most times you can actually visualize how this accident happened. You can also, by judging by the damage to the vehicle and other factors, skid marks, whatever, get some idea of the amount of force, and keep your index of suspicion very, very high. It would pay you to remember these because they are very true. If a patient's been ejected from the vehicle, you really should expect a variety of injuries of all types. If you have a person in a vehicle who was killed and you're working on another patient, your index of suspicion should be very, very high that we have possibly multi-system trauma. A fall greater than 20 feet. Even less than that depending on the surface, but we'll keep it simple and just say at 20 feet. A rollover of the patient's vehicle, all kinds of forces, the axis of force, the direction of force. This might be one of the most difficult to get a handle on how much force and what type of force has been exerted on the body. Just expect everything, because the axis of the force tends to move as the patient rolls within the vehicle or rolls with the vehicle. High-speed vehicle collisions. Cars tend to be a little safer than they used to be. They've got the crumple zones and this and that and the other and airbags and everything else, but speed is speed. Force is force. A high-speed collision is likely to cause a patient injuries. 12 inches or more of intrusion into the passenger compartment. One thing you need to get in the habit of doing is looking at the passenger compartment of the vehicles that you're getting these patients from, so that you can see, get an idea. And when the passenger compartment has been intruded upon, it's a good possibility that the patient absorbed force directly from the impact, not indirectly from the vehicle slamming into something else and them slamming into the vehicle or the seatbelt, but actual direct force transfer from another vehicle to the patient. You don't have armor on a bicycle or a motorcycle, or very little. When a vehicle hits a human body, it can do amazingly traumatic things. I won't go into storytelling mode, but you should always keep your suspicions honed sharp when a pedestrian is struck. A motor vehicle crash greater than 20 miles per hour with the rider leading the motorcycle. Same principle as bicycles. You don't have a lot of armor, and you have the potential for going a lot faster than you do on a bicycle. Blunt or penetrating trauma resulting in an altered mental status. Always should have set off bells for you that something bad's happening here. Vehicle rollover, which I've already talked about at depth, so I won't say any more. Penetrating injury to the head, neck, torso, or extremity above the knee or elbow. Anything close to the core. You have very, very vascular organs in there that can be punctured, ruptured, bleed profusely, never spill a drop outside of the cavity, and still be very severe. And what does this picture tell you about the amount of force and the type of forces? We have a rollover. Looks like we've got an impact to the right. The car's upside down, so that would be the right front of the vehicle. What would your index of suspicion be for this patient? And we also see here someone else up there at the vehicle who is probably, well, two people that I see that are probably not attired the best they should be for being out there. And you can count the reasons for yourself. Other significant mechanisms of injury, blast injuries. Remember, in blast injuries, you actually have the initial blast forces, you have the heat and pressure wave, which sometimes carries heat, and then you have debris injuries. So a lot of force can be exerted, different types of force. Seatbelt injuries, these can be pretty bad. I've seen collarbones broke. I've seen bruises, ribs fractured, chest bruises, all kinds of things. Collision which seatbelts are not worn or if airbags have deployed. Just between you and me and the wall, I'm not all that, I don't get all that excited when I see airbags are deployed, because most of them will deploy at, like 10 miles an hour. But still, make note of it. Impact causing deformity of the steering wheel definitely is going to get my attention. They just took a battering ram to the chest, most likely, or the head, or both. And anytime you have a prolonged extrication extrications can be very frustrating because the clock is ticking. The patient in there, you've got a high index of suspicion, you've got all types of possible injuries, and you're stuck. You're fixed on a point waiting to get that patient out of there so that you can begin a aggressive treatment and then transport. They don't have but so much time. Ouch. More than 12 inches into the passenger compartment or greater than 18 inches to any side of the vehicle. That's a pretty good lick. You can tell that. They got tagged. For kids, our significant mechanisms of injury: fall greater than 10 feet or 2 to 3 times the height of the child. Bicycle collision with a motor vehicle. See these, I won't say frequently, but not infrequently. Pedestrian or occupant in a vehicle collision at medium speed. Unrestrained child in a vehicle collision. Always bad to see. I grew up in the era before child seats. We used to stand in the seat, lay up in the back window, play in the floorboard, all kind of things. And I'm amazed any of my generation survived, but we did. And of course, we're going to skip this. All right. We are just about an hour into this, and it's just about time for me to go home for the day. So I'm going to wrap this up here for part 3 and try to get it up before I leave. It takes a while to render this. So ends part 3. I think we're in the home stretch. So just bear with me, and we'll wrap this up hopefully by this time tomorrow. See you at part 4.